हेलो।
हाँ।
हाँ।
अरे ये यूट्यूब वाला सेटिंग करना है। क्या? यूट्यूब 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 लाइव है ना? लिंक भेज दिए पास लाइव जिसे पंकज सर पे। हाँ। मांग रहा हूँ।
ये बात ये बढ़िया। आप सर आगे जा रहा था। ओके। आगे तो बैठे हैं। पापा भी चले जाएंगे। नहीं मैडम आप पे जाने ही नहीं देंगे। वो जाने आज चेयर बर्तन में है। जाने वाली जी मैडम के स्टेज पे जाने वाली। यूपीआई का तो वही है कहीं में अच्छा थोड़ा सा प्रेजेंटेशन vaginal pain resulting in the UTI. अब वो सर जब आएगा ना तब देखिएगा। इंटरेस्टिंग केस है ना इंटरेस्ट बना रहे हैं। लेकिन हेडिंग मैं तो आज एक्यूट यूटीआई और ये पढ़ के आया था आपने तो मैं तो आज आपके वक्त जाकर मारा था। आप अभी भी कर तिवारी जी हैं आप अभी भी कर लोगे। सर आगे आओ ना
Good afternoon. A very warm welcome to all of you for our monthly scientific meet. So the first case for today is an interesting case of UTI. Presenter is Dr. Anya Kapoor. She is first year resident in Max Vaishali. The case is going to be moderated by Dr. Ashish Gupta, who is senior consultant physician at Max Vaishali. And the session is going to be chaired by Dr. Vandana Garg, senior consultant physician, Max Vaishali. I request Dr. Anya to kindly come over and start with the presentation.
Thank you, Mark. Greetings of the day to all the esteemed members of the DPA. Today we'll be sharing an interesting case of acute vaginal pain with you all. The patient details, she was a 36-year-old female weighing 90 kgs. Her height was 159 centimeters. Her BMI is 35.6 kg per meter square. She was a corporate professional residing in Ghaziabad. She was a follower of Hinduism and she was a devotee. The patient was apparently asymptomatic before the 16th of August 2025 when she developed high-grade fever with chills, intractable suprapubic pain, burning micturition and increased frequency of micturition, whitish discharge per vaginum, and multiple episodes of vomiting and severe nausea. The fever was continuous in nature, reaching a maximum temperature of 101 degrees Fahrenheit with chills without any diurnal variation and returning to normal with antipyretics, which is also associated with severe body pain and suprapubic pain. The suprapubic pain was severe, intractable, spasmodic, and radiating to her groin area and not responding to any pain medications. The patient showed to a local doctor outside before presenting to the ER, who prescribed her some pain medication and antipyretic drugs and advised her for routine testing, which revealed her hemoglobin to be 8.07 grams, platelet 231, her TLC was 6.2, HbA1c was 9.5, and her urine routine showed 40 to 50 pus cells with 4 to 5 epithelial cells. Her vitals at the time of admission, her pulse rate was 90 beats per minute, regular rhythm, normal volume, no radial or radiofemoral delay. Her BP was 126/70 millimeters of mercury. Her oxygen saturation was 98% on room air, and her random blood sugar was 213 milligrams per deciliter. She was also febrile when she presented. Her temperature was 101 degrees Fahrenheit. Past history. She was a known case of type 2 diabetes mellitus since 7 years. She was poorly compliant with her medication, which was metformin 500 milligram BD. She underwent an LSCS 7 years ago. She was not a smoker, not an alcoholic. There was no drug abuse history. There was no high-risk behavioral history, no allergic history. Her family history was also insignificant. Menstrual history. Her LMP was 12th of August 2025, and she gave history of menorrhagia. On general examination, pallor was present. There was no ictus, no sinus, no cyanosis, no clubbing, no lymphadenopathy or nor edema. On systemic examination, she was conscious, cooperative, and well oriented to time, place, and person. There were no focal neurological deficits. Respiratory system, bilateral normal vesicular breath sounds were heard. There were no adventitious sounds that were heard. Per abdomen was soft, suprapubic tenderness was elicited, and her bowel sounds were present. Cardiovascular system, both the heart sounds were heard. There were no murmurs that were heard. So then we reached the clinical impression.
At this point, clearly, as per the history and examination, this looks like a simple case of urinary tract infection which we encounter in our daily practice. One thing I would like to add to the examination was when we examined the patient in the ward, she was tossing in bed. It was like a typical renal colic associated with UTI. Our clinical impression at this point of time was a urinary tract infection associated with query, some ureteric stone or kidney stone.
So the patient was started on IV antibiotics, IV painkillers, and other symptomatic treatment. The patient even became afebrile after 1 day, but the vaginal and suprapubic pain persisted. Initial investigations that were done at Max Hospital, Vaishali. Her total leukocyte count showed 10,000 cells. Her hemoglobin was 8.9. Platelets were 343,000. Her KFT was normal. Her creatinine was 0.6, and her electrolytes were within range. Her moderated GFR was 112.83. Her urine routine, even at Max Vaishali, showed 50 white blood cells per high power field. Her LFT was within normal units. Normal limits. Her urine culture showed sterile pyuria. Her paired blood culture showed that it was sterile. There was no organism that grew. Initial imaging, an ultrasound whole abdomen was done, which showed hepatomegaly with grade 2 fatty infiltration. There was non-visualization of left kidney, and the right kidney was enlarged. And obs and gynae,
So, the patient, after 2 days of treatment, her fever subsided, but the vaginal pain, she was in extreme pain, and she categorically said that I am having pain near and around my vagina. So, we sought a gynae consult for a local examination.
and basically her local examination, on PV exam, a linear thickening was felt in the midline in the anterior fornix. The patient was advised for an ultrasound TVS, but the patient was non-cooperative due to extreme vaginal pain and probe tenderness.
But she tolerated for vaginal examination by the finger.
Yeah, that was again very difficult, TVS it was not at all complicated. So it was done, the radiologist said that it's very
Not the finger.
The thing's not open.
Yeah.
Since
So the photos are not showing. The photos are not coming. There were photos on the slide.
after this gynae examination, since the patient had continued to he also did a CT of the abdomen, which again, can you read out the report? Not.
Yes, sir.
इसमें हमारे-
So that slide is not. It's coming up.
So the CT again showed grade 2 fatty liver with non-visualization of the head body and some thickening in the cervix and the vagina.
यहाँ पे ना एक फोटो
Just your service side.
वो आ नहीं रहा, ये ब्लैंक आ रही है.
Now, this was a plain CT
Face तो
because
नहीं
नहीं, नहीं.
the patient did not get consent for a contrast in view of single kidney, which the patient already knew, but she didn't take the history at the time of admission. And so, it's in view of continued pain and not negative ultrasound and CT imaging, we planned a MRI abdomen of the
There's some technical issue. There's some technical issue and the images that we put in aren't coming. All the images are not. This is some older version. Hello. Hello. Sir, on है. Hello. Hello. Yeah, sorry, there is some technical issue, but our images are not loading, so I'll just connect my laptop and show you all the images. This is an older version. Does that still read out the MRI? So we finally did an MRI abdomen without contrast, which showed hepatomegaly with fatty infiltration, splenomegaly. It also showed non-visualized left kidney with a well-defined T2 stir mildly hypointense lesion of size 2.4 into 1.5 centimeters with internal hypointensity, likely debris noted between the urinary bladder and the left fornix of the vagina, indenting and compressing the vaginal fornix. A linear tubular structure was seen extending cranially from it for a short length, which was suggestive of a possibility of left renal agenesis with infected remnant of the left lower ureter. Also, what was revealed was a subseptate uterus, compensatory hypertrophy of right kidney, and umbilical hernia with omentum. So our final diagnosis was left renal agenesis with acute on chronic infection of the urethric remnant with compensatory hypertrophy of right kidney with intractable vaginal pain not responding to any pain medications and or a fentanyl patch that we had to resort to finally with a subseptate uterus. She was also followed a case of type 2 diabetes mellitus. Connect my laptop. So images के लिए मुझे अपना laptop this. Yes, sir.
We suspect this because more, because this is a very unusual case. The GP is not doing anything. And sometimes the CT is normal and there are no pepper type one going on.
Yes, sir.
So it means there is some difference between CT, pepper and MRI.
Yes, sir.
So I think this case, MRI will be more, better, making, to look out into this, doing that and all these probably. And it is not bigger. It will maybe better advice, other than.
Yes, sir.
Yeah. We were suspecting or calculate because we thought that it to be going for CT first. We thought it would be calculate till then it was not confirmed by we went for CT of and once it the pain persisted, it didn't get a fentanyl patch or not then we had gone for.
But images, there are much distance.
Yeah, the patient actually had to pay right for GKT of vaccines of the pandemic clinic. So her TPA got denied and then she had to pay all that. And patient was almost 5 days in vaccine. Followed by a surgery which. And sometimes not these patients are developing functional report for that. They are, developing functional that the city is normal, the from yeah, we discussed this with radiologists also, since it was a main city and as per radiologist, because the evaluation of the patient and so almost the same. I think it could not take the vision of. Yeah, contrast would have been better. Doesn't work. Even for that.
Doctor, I have a question. Why did you prefer between two choices, CT and
Objects are not available.
you did the CT.
Because the impression I find on some feeling.
Because CT is better.
मुझे यहीं पे
अगर CT एक्सेस को ग्राउंड में है कुछ पता नहीं लग रहा है तो हमारा ही बेटर है हाँ ये इसको फिर पहले हमारा ही क्यों नहीं किया और then उसको स्टेनल बोला जाता है
Hello. Yeah, so we have the images. So we did an NCCT KUB before because we were initially suspecting renal colic. And we wanted to rule out the possibility of a renal stone. And this is what we saw on the CT.
रीनल कौन साइड का बेटा वो नहीं बताया आपने
Left-sided acute vaginal pain tha. So we saw that this is the antibiotic, and then we saw that there was thickening of the uterus, and it was okay. And we can see that there is no difference in attenuation, and that's why the radiologist advised us, as ma'am sir said, for an MRI abdomen, as her symptoms were not resolving. Then we went on and did an MRI, and we found that in between the vagina and the bladder, there is this cystic lesion with internal debris with inflammation all around it. This is non-visualization of the left kidney. We can also see a subseptate uterus that was also an incidental finding. We can see in the sagittal section the hypertense lesion with the central necrosis. We can also see the senially extending uterus or ureter. And this is the section before it where we can see that there is the cystic inflammation. The patient was initially started on ceftriaxone and Niftran along with rotavirus. Oh, of course, yes.
Very interesting to note that late I wanted nothing late. But sometimes it is only in and getting. That's why we got denied.
What was told earlier that be careful about it.
By one uterus as well.
Yes.
But
No, she did not know. So she did not know about her biconvoid
The
uterus.
ultrasound report came, they asked for it.
Hmm.
We know about that now. But basically coming with pain and patients or pain, but it is that the patient had right. Because
Thank you.
most of the time, but sometimes don't know your fertility and looking at ultrasound don't know your fertility. But patient is not having issues with fertility, patient has issues with different region.
So surgery, we had to go for a urology consult. And then we had to, so the patient was initially started on ceftriaxone and Niftran along with rotavirus and SOS and tramadol BD and other supportive management.
Even on these pain medication are pain.
Her pain.
It was like continuous type of pain.
And then we had to eventually apply a fentanyl patch, which also resulted to be not very effective. So then she went for a CT plus robotic assisted pelvic mass excision of queried left ureteric stump on the 23rd of August 2025. Laparoscopic in-job findings revealed that there was a cystic pus-filled mass approximately 2 into 3 centimeters present in the left vesico-uterine pouch with one end extending up to the iliac vessel, crossing the iliac vessel with dense adhesions around the mass. The vesical end of the mass densely was adherent with the bladder, which was actually giving us a UTI-like picture in the beginning. The pus specimen and biopsy specimens were sent. The biopsy revealed a ureteric segment with acute on chronic inflammation, and the pus culture was sterile. The patient was followed up in the OPD. There was no pain. The repeat urine routine showed no pus. Review of literature. Adult cases of congenital renal agenesis presenting with infected ureteric remnants are rare but documented. They're actually more common after a nephrectomy. They often present with unusual infections related to abnormal embryological connections and require both imaging-based diagnosis and surgical management for cure. Chen et al. In 2019 published a case report, ureteric bud remnant with renal agenesis in a 41-year-old male presenting as scrotal discharge. Devatkar et al. In 2017 published a case report titled Left Renal Agenesis with Left Ectopic Ureter Opening into the Vas deferens with Urinary Tract Infection, managed conservatively, a rare case report in an adult male done in Gujarat in India. So Roor et al. In 2022 published a case report, unilateral renal agenesis, blind ending ureter and ectopic ureterocele inserting into the seminal vesicle, a very rare developmental association. However, there was no abnormal embryological connection to any genital structures found in our patient, making it an even rarer case. There are documented case reports of congenital renal agenesis with infected ureteric remnants in female adults, though such cases are exceptionally rare. One such case was found when we were reviewing our literature. Petsick et al. Published a case report of an adult female titled The Remnant of a Congenital Blind Ending Megagerator in a 23-year-old woman causing chronic pain and urinary infections in Prague. Unique features in females were found. The genital tract anomalies often coexist, including uterine diadelphys, obstructed hemivagina, and fistulas involving ureteric remnants. Example, Herlen-Werner Wunderlich syndrome, Gartner's duct cyst, etc. Presentations may involve infertility, which is also not found in our patient, abnormal discharges, pelvic pain, and persistent infections. Pathophysiology. The blind-ended or ectopic ureteric remnant results from failed embryonic development in the absence of ipsilateral metanephric kidney formation. Chronic infection is favored by stasis in the remnant structures, either blind ending or aberrantly communicating with other structures of the genital tract. Further review of our literature revealed that left-sided renal agenesis is more common than right-sided. Left-sided renal agenesis is more common, most likely due to subtle differences in the embryological development, the vascular supply, and possible genetic or environmental factors, though no single definitive mechanism has been proven. There was another exception that we found, which was that female anomaly exception, which was found that meta-analysis revealed that females with combined genital abnormalities, like our patient, and unilateral renal agenesis are actually more common on the right side. But our patient presented with left-sided renal agenesis, making this a notable exception to the left side predominance rule. Common urogenital malformations associated with renal agenesis can be urinary tract anomalies, genital tract malformations in both females and males. So, ureteric agenesis, blind ending ureters, ectopic ureter, duplicated ureters, ureterocele, and megaureters presenting with BUR, vesicoureteral reflux, uretropelvic junction UPJO, bladder extrophy, diverticular, and neurogenic bladder can be present. In females, there can be uterine diadelphys, biconduit uterus like our patient, hypoplastic or absent fallopian tubes, and abnormal external genitalia. Associated findings may be primary amenorrhea, abnormal vaginal development, and infertility. In males, there's the Zinner syndrome that may be present, which is a triad of renal agenesis, ipsilateral seminal vesicle cyst, and ejaculatory duct obstruction. Cryptorchidism and other ductal defects may be present, and which may also present as absent vas deferens or seminal vesicle abnormality. Thank you.
Thank you, Dr. Anya, for the nice presentation. Any questions?
I Dr. Again, this is the first presentation. You ready? Like, we put round of applause to Anya. He's very confident, right? So, those the first speaker. Right. So, no, she put it take message.
The take-home message is MRI better than CT.
Cystitis.
Don't hide your medical history with doctor. Don't hide medical history.
No, I'm just asking if there is a cystitis, which modality, MRI, cystogram, or CT cystogram is better?
Ultrasound की आदत है.
उसको जरूरत नहीं. एक तो मेरा पर्सनल पेशेंट का वो क्वेश्चन है सर, एक परसिस्टेंट उसको मैंने 2-3 बार एंटी फंगल दे दिया आपको, फिर भी उसका क्या कहते हैं ना वो आ जाता है, ये फंगस आ जाता है, और उसको मैं ये फ्लूकेनाजोल के पूरे खोल कर क्या करना है?
डॉक्टर आशीष
यूरिन की वजह से आया था मैम, इसको मैं बंद कर दिया, उसके बाद एंटीबायोटिक एंटी फंगल से कुछ दिन सबसाइड आता है.
I think one more thing I would lost, which email was going to give it. She is doing very well. I will take the normally for certain since very beginning. But she developed status now. Why? Was it because of uncontrolled diabetes or something?
Not infected.
Yeah, how? She never faced the such type of pain.
She might be having some pain initially also, might complain, but she
and she might be knowing that. That might be possible, right? If she has so much serious pain, I don't think she would ignore it if she had pain.
She has a
No,
history of a
Normally
very
has in there.
uncontrolled diabetes, it must have led the terminal to get infected. That uncontrolled diabetes must have led.
You know, 9.6. Yeah. You want
Thank you. Now we'll proceed to our next case, which is an interesting case of progressive dyspnea. Presenter is Dr. Upanshi Madan, second year resident, respiratory medicine at Yashoda Hospital. It is going to be moderated by Dr. Shekhar Vashne, senior consultant pulmonologist from Yashoda, and Dr. Ankit Sinha, senior consultant pulmonology from Max Specialty, is going to chair the case. I request Dr. Upanshi to start with the presentation.
No, I think not a level, no, I think they don't, I think not, moderate. And, Dr. Kewal is of county district, he is a resident, country. I think, very well. I think this is also a first, experience and degree, country. New people presenting. Even that kind of daily, but I mean. Lot of, you can do something like that. You can get exciting.
इसमें नाम रहेगा इसमें साइड
इमेजेस चेक करा मैं सारे है ना सारे इमेजेस
वो आपने पढ़ नहीं पाया आंसर करो आज मैं आ गया वो हेल्प करने के लिए बच्चे का वीडियो भी दिखती है आप पारे में लोग करते काम के थैंक यू हेल्प दे वो भी बनवाएगा
Good afternoon, everyone. Myself, Dr. Upanshi, DNB resident in pulmonology at Yashoda Super Speciality Hospital. Today, I'm going to present a case of an interesting case of progressive dyspnea. The case history of the case is there was a 33 years old male teacher by occupation with no known comorbidities. He presented with high grade fever since 3 weeks, cough not associated with sputum production, and gradually progressive in dyspnea on exertion, which was progressive in nature from MMRC grade 1 to grade 3 over 2 weeks. The nature of fever was high grade, continuous, not associated with chills or rigor, not associated with headache, not associated with night sweats or weight loss. There was no arthralgia, rashes or burning micturition. There was no abdominal pain, diarrhea, vomiting, and no history of recent travel or contact with TB. This rules out the gastric etiology and the neurological or some atypical infection due to some travel. The cough began 2 weeks ago, which was gradual in onset, progressive and dry in nature. It was not associated with hemoptysis and there was no positional or diurnal variation and no aggravating or relieving factors. Dyspnea also began 2 weeks ago, which was gradual in onset, progressive in nature, from MMRC grade 1 to grade 3 over 2 weeks with no history of orthopnea or paroxysmal nocturnal dyspnea, and there was no positional variation. It was not associated with chest pain, wheeze or leg swelling, thus ruling out the cause of DVT which could cause pulmonary embolism and that was aggravated on exertion and relieved on rest. On examination, the patient was normal built, febrile, tachypnic and under respiratory distress. There was no pallor, icterus, cyanosis, lymphadenopathy or edema seen. The vitals were the patient had tachycardia at the time of presentation, which was 152 beats per minute. The temperature was raised. His oxygen saturation, peripheral oxygen saturation was 61% on room air. On auscultation, there were bilateral crepitations, and on percussion, that was normal initially, which afterwards progressed to dull note bilaterally. On investigations, CBC showed leukocytosis. TLC count was 26,530. KFT was initially normal, that gradually worsened the creatinine levels that reached to 3.2. ESR was high, 45. CRP was also raised, 3.1. The patient also had sepsis at time of presentation. The PCT was 1.1. And D-dimer levels were also raised, 1,349.
So that, what was the next thing?
So, on the basis of history, it seems like an infectious etiology. And on examination findings also, so there were crepitations that could be community-acquired pneumonia.
Because the PPT was on the higher side, the RP was on the higher side, and conditions of the lower age on the higher side. First thing is usually thinking about the activity level. And next thing was we are going to further like see the CT scan how the actually that
Stress, so there was diffuse haziness bilaterally. So I put CT images.
It is very,
thanks to the CT immediately.
Yes, sir.
So, such a low simulation, like interstitial pneumonia will be more like.
Remember the history in parallel, it was from 2 to 3 weeks. Fever was from 3 weeks.
parallel thought student.
Yeah, viral will be few days every day from the few days. But that's what he was not going in favor of viral. So something like something should be there. This is the CT scan of the vein.
On CT scan, there was bilateral patchy consolidation with ground glass opacities, and there was a cavity also seen in left upper lobe cavity with. So that is not visible due to overlapping.
Just in my
So minimum
last
left color, minus color, left. So need
the cavity can be filled that cover cavity was there. And also there are multiple ground versus concurrent capacity is there. More in cytoplasm than lower lobe water there. But it is involving more of the upper lobe. You can see that there is a more involvement of the upper lobe bilaterally, upper lobe involvement is there. Facial predilection of that shadows with the left upper lobe is showing a thick wall cavity. Because the cavity is a thick wall. And even in the just we can see in the lower phases there is a interstitial thickening and like the interlobing structure thickening is not smooth, it is a beaded appearance. Most probably now it looks like a mini infective one. With this also we can think of because the cavity is there and concurrent capacities with the interstitial. So he was not a diabetic.
No, sir.
So normally
No comorbidities, sir.
the cavity is going against the viral.
yeah.
Yes, sir.
Because gravity take time to right. So definitely some acute on chronic thing is going on which has increased in last 3 weeks.
But that wall cavity can be there in the step.
So the people have any like but then when we think that cavity, inner cavity, that develop multiple because it goes by blood stream. This will be having small cavity, multiple cavity. Yeah. So that is the one thing like the staff and all not like.
Not as predominant of upper lobe, vital follow.
Yeah.
That is more than.
I don't know she has not given the lower lobe. Generally, with this and even the lower lobe, so more of the ART is like itself is there. The patient, but it is only involving the upper lobe only. So that was with the. I don't know how is the lower lobe.
So they were diffused. There was diffuse
Even the
involvement.
vein is in the lower lobe also.
Yes, sir. And the patient also developed hemoptysis later on after a week of admission, which was not present initially before admission. So, video bronchoscopy was done to check for the cause of hemoptysis. There was purulent material seen on the wall of the trachea and bilateral sanguineous secretions, which can be seen in these images.
You see that the mucosa is also very inflamed. With the bronchoscopy, you can see that there is fluid material is there, and the mucosa is very frail and bilaterally hydraulic mucosa is there. So patient immunocompromised immediately. Nothing was there.
No, sir.
Nothing.
There were no comorbidities. Sir.
What was the intention of going on bronchus? Because of bronchus. Because of bronchus or because of generally when the patient are having hemolysis and the patient has the biochemical, so then once the patient has a having mild hemolysis, not if they have moderate or severe hemolysis, so shouldn't be going for the bronchoscopy. But in the mild hemolysis, we can go for bronchoscopy to check from where they come out and we can find the diagnosis also. But only in the mild hemolysis. Once the patient is having moderate to severe hemolysis, we avoid doing bronchoscopy that time.
And lavage was done from the bronchoscopy, which was sent for pyogenic culture, which was positive for Pseudomonas aeruginosa. And fungal biofire was also done, that was positive for pan-fungal DNA. So for the first time, he came from the community directly to the hospital.
How many patients? You know, operation.
So,
It is like from the positive 500 agents, it is positive for the most of the function.
But yeah, for many people.
in view of these in these reports, the patient underwent autoimmune workup, which was negative for ANA and DNA profile. ANCA workup was done, which was negative for C ANCA, but patient was positive for P ANCA.
What autoimmune disease was this?
So some vasculitis, because there was hemoptysis present in the patient. So to rule out vasculitis, we worked for ANCA antibodies. So renal involvement also. Initially, the creatinine levels were normal. They gradually worsened. So I showed the creatinine levels that reached to 3.2 afterwards.
पहले भी vasculitis की कोई बेटा history थी?
So there was no previous history. That was the first acute presentation, sir.
So vasculitis presenting as an acute presentation.
This can be vasculitis can present like this. DH condition, it is also hemorrhage, and they can have cavity also, and generally this looks like this kind of patient. And once the patient having like bleeding inside, they got infected also. So that's why whenever they are having hemolysis, we generally give cover for the antibacterial. Because the blood is a very good source for any infection. So whenever we are having hemolysis, we give antibiotics, cover any secondary
So
bacteria.
apart from antibiotic, what I have got a lesson that the steroid also should be given to cover the
Okay.
vasculitis.
Once the patient has from the ANCA positive, they have to give them.
So rule out pulmonary embolism, progressive dyspnea.
So generally, each animal at the bottom of whenever the patient having hemolysis, so generally it should be mild hemolysis. That was not mild hemolysis. Even in the pulmonary embolism, they presented like that. So we generally send each animal as a protocol. So whenever we patient were having hemolysis, that's why breast crack. We also give urine routine also for the most of them. Whenever patient having hemolysis, you should be sending urine also just to take the kidney involvement is there now. Just the vaccine can present like kidney involvement also, and they have RBC. So we have so many patients.
Is it a rare presentation or a very common presentation?
So no, it's a rare presentation. The vasculitis directly present to the DH, but 10 to 20% of the vasculitis patients can present it directly to the DH. They don't have any other symptoms directly presenting to the DH. Maybe you will be having some symptoms like upper respiratory tract, maybe but directly presenting to DH, if you have a hemorrhage,
is only 20% of the case of vasculitis.
Sir, I have a question otherwise, like how many cases of bilateral pneumonitis have a component or is a case, they are the case of this thing, vasculitis?
So that's what I say, sir. Vasculitis, this picture. So as I was saying in the capacity also, there is a confluent obesity. So means that it is not directly, not normal picture. Some confluent obesity. So what happens when the blood is there, it get accumulated. That's why you're seeing confluent of your small shadow getting together and causing consolidation. So one shadow, this one. Second thing was the cavity event. So thick wall cavity was there. So cavity also in vasculitis, they can have a cavity renal problem.
No, you said that 10 to 20%
Others,
vasculitis
vasculitis and
can present like this,
Yes.
right, sir? My question is this, suppose we get bilateral pneumonitis like this, in how many cases we will get vasculitis as a cause?
it's very less than 1%.
Less than one.
Less than 1%. That's why the first diagnosis we are taking about the any infected cause because all also the phenomena, fungal, but fungal biagram was it is tied to the cause. Every it doesn't count anything. So, but phenomena were there. So definitely we are thinking about infection also. But the patient has increased hemolysis was there and thick wall cavity was there. So in that or that's why we have seen the vasculitis profile for that. Why it is suddenly developed. When he came in that situation, the non-reacting was normal. It went up to 3 point something. That's why we said the vasculitis CM profile for that.
Doctor, as a GP मेरे लिए अगर बंदा improve नहीं हो रहा है 3-4 दिन में तो फिर steroid दे दो।
That's what I say. It is the reduction is in this kind of person less than 1%. That's why we presented EDTA. If you use the normal cases, you shouldn't have presented the EDTA. So that's what because we also are not thinking about going this is a just infection, but because the thick wall cavity is there, he develops hemolysis also and creating in the admission rate one. So that's why we have thought that it could be a vasculitis also. Where the patient why 13 year why he has got such a bad pneumonia.
मैं तो steps समझ रहा था।
Stat में जैसे stat में जैसे होता है तो मैंने multiple
आपने बताया। Very good. So we are dealing with some kind of a renal-pulmonary syndrome.
Yes, sir.
Working on
So definitely sir, the vasculitis we have renal involvement and pulmonary involvement, and because of both involvement, we have stated the vasculitis profile. So and that CH and PN.
very good from PM. That is nothing that
Definitely sir, we can take the biopsy, kidney biopsy. If you have a problem, we can go for the kidney biopsy, we can go for the lung biopsy. So PN का the false positivity is also it's very rare. That's why we mentioned changing that. We will be saying just the PN का PN and PN का quantitative. So we can doing the quantitative variability. The chance of false positive is very less.
So Manishi, what are you technique? So you said that from basic technique of sample on first it was around 26,000. You don't set them with a not just trying to technique. Right? So we have to do the serious technique. The technique is getting on normal. Possibly again. The technique is, being based, possibly should have, and basic technique is also good. So basic technique is normal time,
Okay,
all the technique not involved initially.
Okay,
It's obviously technique to substitute.
okay.
Positive.
So it was positive here.
What does this say? Daytime generally.
So it is increased in inflammatory conditions, malignancies.
What is the value of positive and negative?
So it has a high negative predictive value.
Negative predictive value जाता है.
Only a negative. And second thing, we can be age satisfied. So if a 80-year male is coming,
10 times
having
the
800 will be the normal value. So it is a age satisfied also. Very important. Sometimes what we do that the older patient, if the DRAM is 800 and we panic that we need something, but age satisfied.
And you work for tuberculosis.
So it was,
We have done the bronchoscopy. We have done the bronchoscopy. Bronchoscopy, the level did not show any. So everything was there.
Professor, normally you compare culture, data management,
Because we can't go again and again. So that's why we go for the bronchoscopy. We always say the Indian country, we are Indian, and we always say the AFP state, E for AT culture, we say everything as to get back to animals. Our and now nowadays, whenever we are thinking of infection also, because we are getting multiple species also, like biofire we are getting. Biopsy was not done. So the biopsy is type of thing. So we are not taking any chances of going for the biopsy. Do we have a trial biopsy available? The chances of but it is very much higher, both the trial biopsy or normal TB. So that's why we are not done for the biopsy. It just because bronchoscopy doesn't be looked at all the HLC. This kind of patient, we don't we do all the HLC. So we get 100% applied go quickly and come as fast as possible, and we do actually everything for that. So because we have in the policy, they like they have given us square patient with good, sometimes we doesn't need that.
तो किडनी बायोप्सी वो करके करेंगे लेके
I mean, good study, is pretty that and one thing was that sometimes in DA patients also we keep doing the bronchoscopy, it gives us the time. We'll take the sequential and it will be more blood, the blood will keep coming and so your the color will keep changing. So that is also one of the diagnosis for DA. So so many hemophiliac patients we presented was we have done the bronchoscopy and we have when we go inside, we have take one request for normal slide with we keep doing that, the color will keep improving. So that is also it is a DA. And then we have intervention for the alpha and delta PHN of the volume profile and it take possible.
so treatment part.
ENT something very good. So there we have a the vendors or we have upper respiratory tract. ENT and after that we have built even the incubator and all.
So the treatment part, the patient was initially managed with IV antibiotics and other supportive treatment and kept on mechanical ventilator support also. The patient underwent CRRT, continuous renal replacement therapy in view of it worsening renal functions, 3 cycles of plasma exchange and 2 cycles of IV cyclophosphamide, and was also given antifungal treatment.
CRRT was antifungal
After the creatinine levels got deranged.
एंटीफंगल क्या दिया
So antifungal boric.
एम्फोटेरिसिन बी
So amphotericin B was not given.
फिर क्या दिया
So itraconazole initially was given voriconazole and then itraconazole.
आईवी
Discussion part, ANCA-associated vasculitis. It is a group of rare autoimmune diseases characterized by inflammation and damage to small to medium-sized vessels, often involving respiratory tract and the kidneys. It is associated with presence of ANCA antibodies. There are 2 types of ANCA antibodies, proteinase 3 and myeloperoxidase. Proteinase 3 is the C ANCA and myeloperoxidase is the P ANCA antibodies. The pathophysiology of vasculitis. First of all, there is formation of ANCA antibodies. These are the, its full form is anti-neutrophil cytoplasmic antibodies. These target the neutrophils inside the cytoplasm. These are of 2 types as discussed, C ANCA and P ANCA. After that, there is activation of neutrophils, which lead to degranulation and oxidative burst and endothelial damage, which leads to hemoptysis and other symptoms. There is vascular inflammation, which causes necrotizing vasculitis and results in organ damage, especially kidneys, lungs, sinuses, skin and nerves. There are 3 kinds of ANCA-associated vasculitis. Granulomatosis with polyangiitis, which was previously called vaginous granulomatosis. Second is microscopic polyangiitis. Third is eosinophilic granulomatosis with polyangiitis, which was also called Church-Strauss syndrome. These vasculitis involve lung and kidneys, leading to cough, dyspnea, hemoptysis, chest pain, malaise and fatigue, but not always as hemoptysis in this case. The types of antibodies can help us differentiate the type of vasculitis. In granulomatosis with polyangiitis, there is C antibody which is positive. So in our case, it was P antibody which was positive. So we can rule out that the patient did not have granulomatosis with polyangiitis. The key features of this disease are necrotizing granulomatosis, inflammation. It involves upper and lower respiratory tract and kidneys. There is chronic sinusitis, nasal crusting and epistaxis due to upper respiratory tract involvement. There are lung nodules, cavitations and hemoptysis, rapidly progressive glomerulonephritis, eye and skin involvement, and on histology there are granuloma and necrotizing vasculitis seen. The second one is microscopic polyangiitis. In this, there is P antibody which is positive. The key features are necrotizing vasculitis without granuloma. There is no granuloma in this kind of inflammation. It primarily affects kidneys, lungs, skin and nerves. The seen in this patient, there is palpable purpura, mononeuritis multiplex, and on histology there is no granuloma, there is only porcine necrotizing vasculitis. The third one is EGPA, eosinophilic granulomatosis with polyangiitis. This also has P antibody positive, but it is different from microscopic polyangiitis in the way that it has eosinophilia, which leads to asthma and upper respiratory symptoms like nasal polyps, which were absent in our patient. There is history of long-standing asthma, allergic rhinitis, and peripheral eosinophilia. There are pulmonary infiltrates, mononeuritis multiplex, skin lesions, gastric and cardiac involvement in severe cases. On histology, there is eosinophil-rich granuloma and necrotizing vasculitis seen. So we can say that this patient has had microscopic polyangiitis. The conclusion is ANCA-associated vasculitis is a rare and potentially life-threatening condition. Early diagnosis and aggressive treatment with immunosuppressants like corticosteroids, cyclophosphamide, rituximab are critical in managing life-threatening conditions. Long-term management involves addressing the vasculitis and monitoring for treatment-related side effects. Thank you. So that could be due to infective etiology.
Cavitation. Also, cavitation is very common in Vaccinitis also even in microscopic polyangiitis, so because the medial side vessels involvement is there, they can communicate like pregnant are commonly they communicate, but even in histophagic granulomatosis or microscopic polyangiitis, they can communicate with that. Because the involvement in the medial side vessels, because of that only, they are creating the cavity.
Why is it that there is no granuloma in micro? That is why there is granuloma in pregnant. Is there a pathophysiology that is known? Why do we have in C and positive in P?
So there is porcine deposits only seen in microscopic polyangiitis. There are only immune complex depositions seen on histopathology.
So, not having granuloma in P and by having granuloma
that the involvement of because there is a possible the involvement that there is not involving the PNK that PNK and PNK, the involvement neutrophil and cytoplasmic involvement. Maybe because of that.
is it T cells? T cells.
No, sir, this is like you have an immune response to that. Most probably, rheumatologist will be better to answer that. But most probably, because the site of involvement both are different. You see in the like monotypic multiplex also, and this one, the microscopic polyangiitis and all. Because there is only the more of a different involvement. Sometimes I enter the medium side vessels and there is more They figure that. ACM that to be write it quantitative. Because it just so some cases that they are not quantitative, they just give delta positive or negative. That is not a proper test. It should be always send the quantitative. How much is the CA curve PM?
But for, say, for people like us, it's better to without and DNA build profile versus output.
So ENA will not give, ENA will not give you the best select. You should see the ENA profile, or whoever lab is doing that. So they are not doing this, extra medicinal antigen. So they are, the vasculitis will be not the part of that. So we have to say differently.
So I think it's a technical general system. All patient relative. Patient might be in rashes. So firstly, it is an autoimmune process going on. Other than this, you have autoimmune disease, hypothyroidism, or type 1 diabetes. What are the autoimmune?
Like our pulmonologist, we in generally in IIT cases, we to ask the cases and we take accordingly.
This kind of attack, like, after you have very clear reviews and your handle.
Yeah.
So I think definitely should be looked out.
Where started. So but this case, whenever you're having this kind of picture color deterioration, and you're having synopsis of kidney involvement, we should be taking a vasculitis. Because we have sometimes this, and then if you do a IV, the pulse squared or cyclophosphamide, they will be very well. But in DH also, the modality is more than 60.
It could be trigger that sets off the total aspect of. Actually, patient was a different one, so short, because this patient is an adult patient, right?
That is
Because infection possibly.
maybe the, but it has been shown that it is no, no legal that, because it is a immune system, sometimes immune, because that if overactive, then it can happen.
Or trigger doesn't even overactivity may be.
Maybe a viral infection, we are the known cause, infection can.
From like, would also like sometimes patients not having this on their day. Sometimes patients both of us can, but I think the immunology of the patient then. So,
TH, patient has more than 60% mortality.
why not the outcome of the patient?
So he is maintaining well. So he is on cyclophosphamide sessions. He on in between. So and rituximab sessions also. So he is under treatment from rheumatologist there.
But all the clinical now. Is an outcome.
And these type of patients, we have to give like cyclophosphamide. So the vasculitis, we have cyclophosphamide or rituximab. So maintenance treatment which have been given for 6 months, and after that, they come the patient decision. Then you have to maintain of like quite.
I think fantastic assets. We have to eliminate one.
Thank you,
Pick
sir.
up the sign. Why she was to be to the point.
Thank you, sir.
And I think when the ethical committee member is also it could be that and I asked them to come to government. Fantastic. You can want to say so.
No, I was not there.
Well, that's what I asked you now. So I think the EDP champion award is given to Dr. Rahul Nathani. Dr. Rahul, sir, can you put your screen? Yes. Welcome, Dr. Rahul Nathani, for accepting our award. I think you are very far off, so I did not come to this meeting. So EDP member sitting just a word of your this is publications. I read 1,500 citations. I think that's wonderful. So it's a huge achievement for Dr. Rahul. And just tell us something about your this achievement and how do you feeling about it, Dr. Rahul?
So first of all, thank you very much. I have a very close association with EDPA, even though I'm not there physically a lot of times, but still, at mental level, we are still there. Actually, there is nothing much about this achievement. The way we have Facebook, similarly, we have a social networking site called ResearchGate, and this is one of that. The ResearchGate is basically an academic social media. So what it does is once you have registered here, it keeps on pulling your data, your publication and all, and keeps on counting the citation. So it's not that someone is tracking this, but whenever an achievement is there, it sends you a pop-up like this. So when it sent me a pop-up, it was 21st of August, that's 1,500 citations. So of course, then we were glad about it. That,
No, just a minute. The voice is not clear. Just give me a minute. I just connect to the system.
yeah.
So just spare a minute so that we could hear. So we can do this speaker system. Dr. Makar can pick.
इसका सेटिंग इसके लिए कनेक्टेड होता है स्पीकर्स तो कनेक्टेड है ना स्पीकर फिक्स है
स्पीकर
कनेक्टेड है ना
There's some glitch in the system. So Dr. Nathani, I think you just record a video message so that I can play on the main group, right? So I can hear you definitely, but our audience could not hear you. So anyways, and this is your award.
Oh,
So
thank
good
you.
round of applause for Dr. Nathani.
Thank you very much.
So
somebody could receive it on behalf of.
one of the. So Dr. B.K. Gupta is receiving on your behalf. That's your award.
Oh, thank you very much, sir.
Dr. Makar, आप दे दो award. So just record a video message and I will play in the main group and regarding your passion about this medical literature and something which is very unusual because you are a busy meteorologist, I know, but and despite that you get time out of it and so it will be sent to you, right? And hopefully we will meet in physical meeting and we'll hand over to you.
Sure.
Thank you, Rahul, for this thing, and you just record a video message so that I can play. Thank you, Dr. Rahul, for receiving this award for this month's champion award for 1,500 citations. It's a huge achievement. So that actually motivates all of us to present to publish our work. We are doing a lot of work, right? But we are not able to publish it because of some time constraints and all. So I think EDP can help in this. I think Dr. Makar, you are an editor, so that
all those who are academically oriented to at least think of doing some studies or publishing something, some paper, whatever, even if it is case reports. I think we should.
And we do
publish that in our at least EDPA.
And we, Dr. Nathani, we have now the EDPA ethical committee as well. So if you want to do some work, yeah, and you want to pass it to the ethical committee, so we will also have to publish in this area, and we are getting good response. First response actually we have done for a work, and we have got a second assignment as well. So I think it is very good. So Dr. Rahul, just request to just record a video message so that we can float in the EDP group. Thank you very much for joining, Dr. Rahul. Thanks.
Should I be recording here itself?
You can get recording. No, you just record your this video message and just give it to me. I'll post into the BDP academic group.
Okay, so I can send it on WhatsApp also. That's
WhatsApp
fine.
group, personally to me, right?
Okay,
Take care.
thank
Bye
you.
bye. All the best.
Yeah, bye-bye. Thank you very much.
But this is YouTube live actually. You are on YouTube actually.
Okay, all right.
So
Thank you.
YouTubers can see your voice and hear your voice, but this audience cannot hear it. But you are in YouTube live.
Okay, yeah, thank you very much.
Okay. Take care. Bye bye.
Bye-bye.
Yeah.